Our next speaker is, like Dr. Pidcock, also a member of the Transverse Myelitis Medical Advisory Board. Gregory Barnes is a
Well, Sandy and Doug, thank you for asking me to come and speak again. This particular topic, we've already talked about much of the diseases here in terms of pediatrics, both for TM as well as ADEM. But I just want to give you a sense as a practicing pediatric neurologist, sort of how do we actually distinguish these diseases when we're actually looking at these in the hospital setting. And is there any data that's out there that's different from what we've seen here from the TM registry? Okay, so these clinical characteristics, of course, we've already talked about a tremendous amount, but we're going to be focusing on these two questions here. How do we distinguish TM from ADEM, and how do we distinguish TM from CIDP? So one of the very interesting studies that came out was a study in pediatrics in 2004 by Mikaeloff et al. That asked the question, how frequent is CNS demyelination events in children? They included children under 16 years of age admitted to 12 pediatric neurology centers in France. And their exclusion criteria included excluding neurological abnormalities, metabolic causes, infectious causes, and systemic immunologic disorder. And what they found is very much what we have heard here today. Their follow-up period was approximately 3 years with 296 patients, a vast majority of which were Caucasian patients. Overall, the age of onset of the first attack was about 10 years of age, but it did in fact sort out between these three different diseases. In multiple sclerosis, the children tended to be older at about 12 years of age. Monophasic ADEM, as we've heard here today already, it was much younger, usually about 7. And the single focal episodes of demyelination, which included a fair amount of TM, was about 9 years of age. So they did separate out in age somewhat. Other distinguishing characteristics that helps us in terms of our history is that infection during the preceding month is much more common either in the ADEM or the focal episode demyelinating event versus it is in children who had a final diagnosis of MS. And this is just to remind myself here that TM was very high, 63% in this particular group. Optic neuritis was much more common in the MS group versus in the ADEM group, and brainstem dysfunction was a little bit more common in the ADEM group versus the MS group. And very characteristic of pediatric ADEM is the fact that there is altered mental status. So these children just don't seem to be right. Even children who are 6 months old or even less than that tend to be very, very irritable, and then parents will say, "Oh, they're just not themselves." The initial MRI findings was also very telling in this particular article. In the group with a final diagnosis of ADEM, the initial MRI was suggestive of ADEM in 100% of those that had this final diagnosis, but also there were characteristics on the MRI in 15% that were suggestive of MS at the initial diagnosis. In the group with the final diagnosis of MS, 57% of the initial MRIs did suggest MS, and 0% were suggestive of ADEM. So the initial MRI can help us on presentation. The distributions of lesions can help us somewhat. Subtentorial lesions are about the same, but involvement of the deep gray matter, usually either the thalamus or the basal ganglia, is usually much more common in ADEM. The involvement of the optic nerve, as you would expect, is much more common in MS. And spinal cord lesions are probably about the same, a little bit more common in pediatric MS patients. And tumor-like lesions may be a little bit more common in ADEM versus MS. But gadolinium enhancement, the inflammatory component, seems to be much more common in those with an initial diagnosis of MS, with a final diagnosis of MS. Excuse me. And another thing that was found was CSF findings seem to be also very helpful. Greater than 10 white blood cells, that tends to be a little less common in MS versus in ADM. You tend to have more than 10 white blood cells. The protein tends to be a little bit more elevated in ADM versus MS, and as has been pointed out before, oligoclonal bands is much more common among pediatric MS patients versus those with ADM. And the other thing that wasn't measured here, but is oftentimes very common, and it's borne out in Rob Russ's series, is that ADM patients tend to have an elevated CSF pressure, opening pressure, when you measure it. Factors that were predictive through a multivariate analysis of a second attack of demyelination include age of onset. An older age of onset predicted a second attack, as well as either the presence of either myelitis or optic nerve lesions, or an MRI suggestive at the onset of multiple sclerosis. Factors that seemed to decrease the rates of second attack included an MRI suggestive of ADM, suggesting that most of this ADM was in fact monophasic ADM. The incidence of pediatric acute transverse myelitis. This is data from the previous study that was presented by Dufresne and et al. In the Journal of Child Neurology in 2003. The incidence is probably between 1 in 100,000 and 1 in a million. They reported on 24 patients, and they defined acute transverse myelitis as onset of bilateral spinal cord dysfunction, and their exclusion criteria included previous neurological illness, evidence of trauma, radiation, or spinal cord compression. Their median age of onset, very similar to what they found in the Hopkins registry, somewhere around 8 years of age. The male-to-female ratio was 1 to 1. The antecedent illness was present in about 58% of the patients, and about 50% of the cases were in the winter season, and fever was present in about 60% of the patients. In the initial phase, and in the initial 5 days, which is something that you ask, in pediatric ATM, pain is very present, and it's usually present over one or more spinal segments, and of course they also found that in the Hopkins registry as well. And very similar, besides the back pain, the symmetric flaccid paralysis of the lower extremities with sphincter dysfunction, the sensory abnormalities were also very, very similar, 75% and 82%. Sphincter dysfunction was severe and was severe in 83%. It was 83% overall of the patients, and was severe in about 50% of the patients. Those patients were all treated with 20 mg per kilo of IV solumedrol, and were followed with a mean of 7 years. The median time to independent walking was about 60 days, and as I commented before in here, the recovery time in ATM and ADEM usually is somewhere around that you start seeing a lot of progress and improvement by 1 to 3 months. And there's 24 patients, about 50% of them had a normal recovery, with 13%, 24%, and 13% having mild to severe motor sequelae. So a little bit different than what was seen in the Hopkins registry. So obviously it's going to take us a lot more higher numbers for us to really investigate the outcomes probably correctly. The outcomes, they did in fact identify the time to maximum deficit as less than 24 hours as one comment that predicted an unfavorable outcome. Favorable outcomes included plateauing off of neurologic deficit less than 8 days, and the time to independent walking being less than 30 days. And none of their patients had a recurrence of TM or other neurological deficits, and none of them developed MS. So that was unlike what we've seen in the Hopkins registry. The CSF abnormalities were seen in about 62% of the patients. Most commonly, you had elevated white blood cells. They, in their group, found about an average of about 200. Only about 3 of 24 had slightly elevated protein, which is, I think, is a little unusual for TM myself. And roughly about 20% of the patients had some recent evidence of some sort of viral infection. None of them, of course, had oligoclonal bands. And the MRI that was seen with all the patients had swelling and increased T2 signal. And it's really been my experience, as well as the experience that's been reported by other investigators, that the myelitis that you see in pediatrics is really throughout the patchy and asymmetric throughout the cervical and the thoracic regions. And they saw increased T2 signal located centrally in the spinal cord as well. Now, how do you differentiate that from ADEM? Well, typically the pain is usually over the back in kids with transverse myelitis. In kids with ADEM, they're irritable because their neck hurts. They actually have a lot of meningismus or inflammation of the meninges. And of course, this is an inflammatory demyelinating disease that's typically monophasic. But about 10% of the patients, as we heard, are either biphasic or multiphasic. And there's some sort of usual event or vaccination that precedes by 1 to 4 weeks in about somewhere between 50 to 75% of the patients. And typically, the interval between some sort of prodrome to the onset of neurological symptoms is roughly somewhere about 2 weeks. And the age of onset is usually in the 5 to 7 age range. And this is data from the Tenenbaum series that was published in Neurology in 2002. They looked at 84 consecutive patients in Argentina. And if you look at those that had either a nonspecific URI, vaccines, GI bug, and either varicella or some sort of encephalitis of some sort, that roughly comes out to about 75% if you add up all those percentages, and which is roughly within what the literature's shown so far. In their particular patients, changes in sensorium, acute hemiparesis, and cerebellar ataxia were the most common signs that they found. And in fact, this is the sort of the triad of symptoms that Rob Russ has also found in his unpublished series of about 150 consecutive patients. Seizures tends to be a little bit more, tends to be very common in ADEM versus it's not very common in multiple sclerosis. And headache and vomiting in some series is much more common, and you saw that presented in earlier earlier talks. In this series, it was only about 24%. Visual loss, aphasia, extrapyramidal signs, and hemiparesis actually were fleeting in some of these syndromes. The radiologic groups, I think we've gone over those before. The usual presentation is this group A, where you have these asymmetric patchy lesions that are all over the brain, usually in both the gray and in the white matter, predominantly in the white matter, but you should see some in the gray. You can have these confluent asymmetric and tumor-like lesions as another group. And oftentimes, Group A and Group C sort of intermix. You can have these white matter lesions in combination with deep gray matter. And this last group is not very common, a large demyelinating lesion with hemorrhage. The hemorrhage can actually be enough to actually cause the patient to herniate if you're not careful. In their particular patients, they had 28% of the patients that had cells that were less than 180 in the CSF. And about 38% of the patients had an elevated protein. And as you can see, oligoclonal bands are not very common in pediatric ADEM, and only 13% of those patients had an elevated CSF IgG synthesis rate. And again, with either elevated myelin-basic protein or antibody or PCR evidence of recent infection is very small in these patients. In the Tenenbaum series, 80% of the patients got solumedrol, and 35% of them had to have anticonvulsants. They got put on acyclovir. About 40% of them were in the ICU, with about 16% of them actually receiving ventilation. So what they did with their groups is they gave IV solumedrol followed by a PO steroid taper over the 4-6 weeks, which was pretty standard. Their follow-up was about 6.5 to 7 years, and they ranked their disabilities by MRI scans. And if you look at those that had these scattered white matter or gray matter lesions, then about 96% of the patients become normal. And if you look at the group B and group C, those that have deep gray matter lesions, or they have these tumor-like lesions, a large majority of them have a good outcome as well. But at group D, those with have hemorrhage, it was only 2 in this particular group, but only 1 or 2 of them actually ended up having a good outcome. And this is what they found in terms of their neurodeficits. Mild to severe hemiparesis was present in 8%. Symptomatic epilepsy, which is commonly pretty severe, it was found in about 6%. Visual acuity reduction in about 6%. And this mental handicap was not tested very well in this particular series, and actually in my experience, cognitive handicaps are actually much more common in ADEM groups, usually involving either frontal lobe or parietal lobe symptoms, so kids who have problems with attention, directed attention, hyperactivity, stuff like that. We've talked a little bit about multiphasic ADEM. It happens in up to about 10% of the ADEM cases. The patients tend to be a little younger in terms of the age of onset and tend to have about 1 to 2 relapses. And the mean interval between relapses has been found to be about 3 years, and they usually don't have oligoconal bands. And if you look at the reports, this is the longest report, those of 8 years. So it may be that if you follow these kids out 20 years that you might find that they have more relapses. So again, we're still trying to define what this disease is. Now, pediatric chronic inflammatory demyelinating polyneuropathy, or CIDP, is very rare, either 0.5 to 1 to 100,000 patients. These kids have a subacute onset of both proximal as well as distal weakness over at least 2 months, and the research criteria includes progressive or relapsing motor and sensory function of more than one limb and hyperreflexia or areflexia of all 4 limbs. Again, there's not a male or female predominance, and these kids tend to be older, which is one of their more distinguishing characteristics. There are 2 groups. First group, there's a progressive loss of ambulation over a number of months. They're often improved by treatment and tend to be monophasic in their course. There's a 30% of another series actually had a presentation that looked very similar to Guillain-Barré, and 83% had of another group actually had a progressive loss of ambulation over 3 months, and those kids tend to have relapsing courses with an average of about 5 episodes. The symptoms they experience besides motor symptoms include fatigue and sensory symptoms, including dysesthesias and sensory loss. Only a very small percent of them ever had any problem, any need for ventilation in the ICU. The electrophysiology here can be pretty helpful. In CIDP, the conduction velocity, of course, is non-uniform slowing with conduction block, and that's very, very common in this versus in transverse myelitis, where the conduction velocities are going to be normal. And sensory velocities are also impaired as well. Transverse myelitis tends to be more acute in terms of its onset. The hereditary motor sensory neuropathies, which is another differential diagnosis here, tends to be more distal motor loss, and sensory loss tends to be more severe than CIDP. And they oftentimes have a dominant inheritance as well. And the nerve conduction velocities are a little worse in terms of compared to CIDP. Acquired myelopathies can look like this. Dermatomyositis can look like CIDP when the rash is not present, but CKs are usually elevated with these myopathies, and they're not elevated in CIDP. Also, autosomal recessive neuropathies such as the leukodystrophies, metachromatic leukodystrophy, Krabbe's disease, or it can look like CIDP. But the peripheral nervous system involvement can, in fact, precede CNS symptoms in this. And, of course, you don't have brain symptoms with CIDP, so an MRI can be helpful in this particular situation. And the pathogenesis is really a humoral immune response. Some of these patients have elevated intrathecal IgG synthesis and you find autoantibodies against a variety of neural antigens, principally in the gangliosides and sulfatides. Corticosteroids, if you give to patients, have a high response rate, and IVIG also has a very high response rate, about 70%. And plasma exchange can work well as too. So the CIDP prognosis tends to be of two things. One, in this monophasic illness group, they tend to have a full recovery, but those that are in the relapsing group, they tend to have these 4 to 5 relapses that occurs over about 7 years. And if you look at short-term studies, 12 to 60 months off of therapy, it suggests that children after this have little or no motor deficit. However, these have not been followed out longer term, but they're thought to be excellent compared to if you talk to neuromuscular specialists. So that's how we distinguish CIDP from TM and ADEM. And thank you for listening.